Dear Chairman, dear colleagues, and dear friends, it's a great pleasure to be here with you, presenting work in the context of the Gemini project, which is about digital twin in stroke patients. Today, more specifically, I will talk about decision-making in the management of intracranial aneurysms and discuss taking decisions, applying rules versus taking decisions, understanding mechanisms. Our principal aims, all of us doctors, is to reduce the burden of disease. And in particular in that project, we will develop a tool and interact with the community to be able to decrease progressively the burden of a disease based on evidences. Here, there is a graph which shows the probability of an event as a function of intracranial aneurysms. And what we see here is that there is a number of patients that do suffer disabilities as a result of an aneurysm, either rupture or an aneurysm diagnosis, which ended up to an intervention that induced some disabilities. What we see over time is that this distribution of patients with intracranial aneurysm that are incidentally diagnosed doesn't change on the right side. But on the left side, we see that there's progressively an increasing number of small aneurysms discovered. We therefore assume that there is actually an exponential decay of aneurysms as a function of aneurysm diameter. What we do in that project is develop a tool that allows to predict the burden associated with characteristics of intracranial aneurysms in patients. And what we want to do is progressively, by giving tools that allow to improve the decision making, to reduce that burden progressively to zero. The current strategy adopted by the community is to first find ways to identify the people at risk and then develop new treatments, involve and choosing what is the best treatment for a specific patient and a specific aneurysm. And what we lack of is information to actually better optimize those two decisions. We so far have the PHASES score to identify people at risk. We have the UTS score, which balances the benefit and risk of natural history and treatment. We have the UCAS score also that allows us to take some decision and were regularly used in clinic. But we all think those tools are not precise enough. Now, in contrast, we have tools that allow to have a very high precision. And this is just an example of different tools that were developed using patient information, aneurysm shape information, and flow information to actually predict the risk of rupture. And what we see here is that we have a tool which is a random forest tool, which achieves 94% area on the curve of the receiving operating curve, which is fairly good. But those tools are not adopted in the clinic because they're difficult to implement, because they need a high level of technicity, and because most of the people ignore those tools. And on the other side, we see that, and that's a very recent paper that was assessing the results of surgery in an international study looking at difference between gender, male and females. And what we see is that the mortality is still around 0.8%. The disability rate is still a little bit lower than 8%. The retreatment rate is still about a little bit less than 4%, and the occlusion rate is a little bit less than 95%. Those numbers are good, but they're not enough. We could do and we have to do better. And the results are very similar for endovascular treatments. So what we do is, if we need to select the proper treatment for the proper aneurysm, and if we use the proper treatment, we actually might be increasing the occlusion rates, we might increase the disability and the mortality rate. Currently, the principal limitation we identified is first a framing bias. We know only about 3.3% of our patients. 96.7% of the patients ignore they have an aneurysm, and we ignore what happens with those aneurysms. And most probably, the distribution of people having aneurysms is not homogeneous. Most probably there are lots of very benign aneurysms, and we only see the most aggressive aneurysms. So taking decisions with an experience where we have access only to the most aggressive aneurysms lead us to be too aggressive. The second limitation is the fact that so far, with the tools we used, we always had to accept the assumption that the different variables we work with are independent, which is not the case. Here you can see that the only three variables that are independent is sex, family history, and age. All the other factors we take into account in our models are interdependent. They are influencing each other, which make that logistic regression and any other regularly used statistical tool is not correct. Finally, the third limitation is the fact that everyone is doing one study, using its own standard operating procedures, using its own definitions. And when we receive data from multiple centers, what we need to look at is find the common denominator. And if we look at the common denominator, we always lose information. So we really have, and this was the big effort of the common data elements, we have to adopt those common data elements. We have to adopt standards and the way we assess our patient and reports and the way we populate our databases and data bank. And here I really encourage people to use the RDF and to use the concepts of linked open data. So far, what were we able to do? Well, we used Bayesian network graphs to actually look at the interdependencies between factors and look at the strength and characterize those interdependencies. And here you have a first Bayesian network model based on one center data of about 800 patients that was published in 2022. Now, we now got a much larger data set which contains 8,604 patients from multiple centers. And by doing a mixed effect additive Bayesian network, we actually have here a representation of the interactions, which is the latest available data and which is still preliminary results. So now you see that there's lots of interactions between the factors, and you see that it's quite complex. So what is the solution we offer here to make that usable? Well, we have the possibility to interact with the Bayesian network. We can map the disease and we can explore the disease. So what we can do is here you see all the factors with their distributions according to the whole data set. And what we can do is we can select subgroups. So here we selected a group of females which are not smokers, which are not aware of being hypertensive, with an intracranial aneurysm size, small size, with a high-risk location. And what you see is that in that population, there are a lot of females that are sporadic aneurysms. They have a lot of solitary aneurysms, and that the risk of rupture is quite high. And now, if we change to low-risk location, you see that there's a completely different picture. You see that the risk of rupture is much smaller. The multiplicity and positive family history remains low. What we're doing now is we're adding intervention to that graph, and we're adding disability to that graph. So we will have a complete picture of the disease. And why is it important to have a complete pictures of the disease? Is because that allows us to better manage biases. So here, that's a napkin sketch of vision. So here you have a distribution of patients suffering from aneurysms according to age, male in blue and female in pink. Now you look at that population and you change the x-axis and you look at the number of aneurysms, so multiplicity. And what you see is that in this population, you have a lot of people with solitary aneurysms. We have less people with 2, less people with 3, and so on. And actually, this is an exponential decay distribution. Now, if you look at size, you see what I showed in the first slice. You see that distribution, but with missing values for the small diameters. And we hypothesize that this missing values is that we actually don't report them, we don't see them, but they do exist. So we can correct this bias by replacing the histograms and the numbers, the values observed, by theoretical values, having a theoretical distribution of aneurysms according to location, being different types of exponential decays we have to characterize. Similarly, we can look at the probability of an aneurysm to rupture, and we can actually model this probability of rupture according to location and many other characteristics. We can also model the functions about aneurysm treatment. And here again, we can look at the probability of an aneurysm to be treated according to location and other factors. And from those probabilities of one aneurysm to be treated or to be rupturing, we can actually, by multiplying with the probability distribution, have the probability in the population of aneurysm ruptures in general and of aneurysm treatment outcomes in general. And by combining the disabilities of those ruptures and of those treatments, we can have an overall probability of burden according to size in that population. And again, we can then translate that in the probability of burden associated with different types of aneurysms according to age. So the idea is to look at the distributions, understanding where the bias is, and then get onto theoretical functions that describe those distributions, that describes the mechanics, the biomechanics of the aneurysm evolution and the aneurysm rupture by looking at states, injury and repair mechanisms, looking at the impact of ischemia, vasospasm, and hydrocephalus on the burden of the disease, and all that mathematically integrated in a model. So theoretical distribution, biomechanical models to actually predict the outcome, the burden of the disease. And here we should actually see that the difference between the prediction and the observation should decline. And that actually will be the assessment of our model. And then we can use that model to take better decisions to make the real burden of the disease decline. Thank you very much.